Sure. So when a patient with metastatic castration-resistant prostate cancer is treated with these newer AR inhibitors, a common phenomenon at one of the first bone scans that you're doing to assess whether the patient's benefiting is to see new bone scan lesions. And a bone scan flare we've defined as a patient who's doing really well, the PSA is going down, the soft tissue metastases are shrinking, the patient's benefiting, but yet there's a discordance. There's new bone scan lesions that are seen at that first or second bone scan assessment. We call that pseudoprogression or flare. And in this poster, we demonstrate that flare in the chemo-naive setting has no clinical consequence, that patients should continue to receive their active therapy, that this is really a sign of healing, osteoblastic healing reactions as the cancer regresses, and that there's clinical benefit to continuing therapy. This is actually integrated into Prostate Cancer Working Group 2 and 3 guidelines, but this is the first study to really characterize how common this is. We found that flare was present in about 20% of men. It's a little more complicated in the post-chemotherapy setting, where a bone scan pseudoprogression actually can turn out to be real progression. And it illustrates the fact that we need better functional imaging in bone. Some of the newer PET tracers are trying to solve this for us so that we're not just relying on old technetium bone scans anymore.